Now we have a few minutes to have some question and answers from the audience or from the panelists. I'd like to start the question and answer session by asking Dr. Guagliumi a few questions. You know, Giulio, you have such incredible experience firsthand with the pandemic in Bergamo. What did you learn about the way we evaluate patients with cardiac injury that we could do better, that you perhaps regret or you think we should have done better in terms of, or we could do better now? And are there any therapies you thought empirically were working that we should be using now?
Okay, let's start from the second. I think that the cases we saw were very informative about the importance of the anticoagulation. And despite the fact that we have no evidence-based guidance in therapy, I think that we have enough data to support that anticoagulation is a pillar of the treatment as soon as possible when the patient comes in the hospital. We have observational data talking about full anticoagulation of prophylactic anticoagulation coming from the Mount Sinai in terms of a good impact in terms of outcome. I think that the current anticoagulation that we have in clinical practice is only one piece of what we would like to have. And there were data show tonight about the crucial role, for instance, of the complement and start thinking about inhibitors of the C5 protein of the complement, or we can see differently in terms of anticoagulation, new potential drugs. I think this is one of the essential to be combined with antiviral drugs, and then we needed to have definitely a response from other therapy, glucocorticoids, especially at the inflammatory last phase, or the inhibitors of the cytokines. That is another very promising therapy. But today I think any type of decision is more guided by our sensibility and the clinical practice compared to have already the evidence. So very important to identify the pathophysiologic mechanism to try to focus on more targeting therapy. And regarding the first question that was how we can better characterize the myocardial injury, I think that we needed to take into consideration that these patients are infected. So first of all, we needed to differentiate the ones that have very low and continuous release of troponin. I think that they do not need anything more than to have a continuous serial evaluation and perhaps fast echo and follow-up echo. I think it's more important to have data in the mid-term of a follow-up. For the ones that they are coming in critical condition, like the young lady we saw, there is not too much that we can change in terms of imaging data. They are very quickly going to be intubating. They needed to be supported. We needed also to try to save the personnel to be contaminating. So I think that this is something that remain to be investigated and to be clarified.
Great, thank you. Rajiv, I think we have time for one question because we have a bunch of questions.
Gautam Kumar asked a great question. You know, Giulio, you know, in the use of thrombolytics was sort of brought up by the Chinese initially during COVID, and we didn't really catch on in the United States because of the thrombus burden, and you already mentioned the intramyocardial thrombi. Gautam Kumar asked the question, is there any role for intracoronary TPA to deal with intramyocardial thrombi? And if so, how would you select those cases versus systemic TPA?
Okay, two different aspects. The first one is when the coagulation is changing, the TPA level in COVID patients is suddenly increasing at least 5 or 6 times. So we have a TPA produced at the level of the system, but in fact we have a much more important increase in PI1, the inhibition of the plasminogen activator. So I'm not sure that this suggestion could be completely valid for approaching the microthrombi. Regarding the primary PCI and the use of TPA, we did a completely different. In fact, we avoided to use fibrinolytics and we use systematically primary PCI. I think there is a very important message that is coming from my hospital. In all the patients that we did, we compare COVID positive and COVID-19 treated with a primary PCI. In fact, the P on F ratio is the essential to understand if you are doing futile intervention, because if they are coming in severe respiratory distress, you can do everything, reopening the vessel, but you have a very, very high mortality compared to the COVID-19. So I think there is still a big space for deciding based upon the level of respiratory insufficiency, which type of therapy to approach acute ischemic events.
And I think, Giulio, you know, that you brought up a great point. The reality is that thrombolytics or fibrinolytics works 50 to 60% of the time. And we saw, as did Shripar Bangalore from NYU, that many of the patients who presented with ST elevation had non-obstructive coronary artery disease. So in those situations, if you use just the EKG or even a POCUS with the EKG and gave thrombolytics, you were essentially treating nothing except small microthrombi. And so the utility of that is unclear.
I'm going to ask one more quick question before we go to Dr. Virmani. Stefan Tunev asked a very interesting question. Is there evidence that COVID-19 infects and damages cardiomyocytes directly, or the observed cardiac pathology is strictly ischemic?
I believe it is strictly ischemic, as we did, as you know, look for by PCR for COVID-19 in the hearts, and we did not find COVID-19 except in the left atrium and the right atrium. So I don't believe there is evidence that there is direct involvement of the myocardium at all. Invasion by the virus, by the myocytes themselves.